I'm going to just start the recording. Good morning, everyone, and welcome to our monthly community conversations from HealthAdvocateX. I'm Robin Shapiro. I'm the board chair. And before we get going with our guests today, I'd like to just first establish this meeting as a safe space. And what that means is that every voice will be heard and respected. And we know that everybody brings unique, different life and lived experiences. And as such, we recognize the potential for unintentional harm. And as an organization, we are committed to healing should harm occur. I'd also like to tell you that today I'm speaking from Seattle, Washington, which is part of the unceded land of the Duwamish, Suquamish, Muckleshoot, and Stillaguamish people. And I'd like to acknowledge the Duwamish, Suquamish, Muckleshoot, and Stillaguamish people and community and pay my respects to their past, present, and future elders, and encourage everyone to take a moment to thank the original people and think about them in the places that we live, work, and play. So this month, we every single month, we have such an interesting lineup of people who are coming to speak to us. Today, we're going to start off, as we always do, with Dr. Dale Reisner, who will be giving us an overview on community and public health and what are the hot issues facing our country at the moment. And then we'll be introducing our featured speaker today, Mike Gartner, who will be talking about price transparency and also insurance denials, appeals, how to navigate that a little bit better. So with that, I would like to turn it over to Dale.
Thanks, Robin. And I think you guys are going to be really happy to hear from Mike. I'm going to keep my comments relatively short and will black myself out while he's talking. So I'm not going to talk. I'm going to only mention COVID once today. But I wanted to kind of overview public health. We're going to focus a lot of our updates from a public health perspective. And probably many of you on this call know a little bit about public health, but you may not really understand everything that public health does. It certainly was in the limelight with the recent pandemic, but public health has been around for a long time, and it's meant to promote and protect the health of all people and the communities where they live, work, and play. And so it is where most of the advocates that are on the phone, not all, but are working with one-on-one clients, is really focused on the population and different communities, and knowing that different communities have different needs. So, for example, in the state of Washington, we have a state public health officer, but we also have public health officers that are in charge of at least the larger counties. So King County, Snohomish County, there's not every single tiny county, but where the issues may be more evident around all of the things that contribute to public health. So I wanted to just briefly mention who really is in the field of public health. And you guys are actually all part of it because it's advocates for health. And so there are first responders, there's restaurant inspectors, and all of the health educators, scientists and researchers that look into the things that impact our health and our wellness. Nutritionists, they're community planners, social workers. The three groups we might think about most prominently are epidemiologists, public health physicians, and public health nurses. Those are more likely to be, employed by the public health department, but also OSHA workers, other public policymakers, and even sanitarians. So, when you think about our whole environment, one of the things that I think is important to understand is that public health doesn't only do disease outbreak tracking, and the breadth of their outbreak tracking includes things like COVID, but also sexually transmitted diseases, tuberculosis, all kinds of communicable diseases that we not be thinking about on a day-to-day basis. It also speaks out for promoting smoke-free interior air, looks at seat belts. You guys all know that it's involved in vaccinations, not just COVID, but for measles, mumps, rubella, all the other things that can impact our communities. And that with the ideal of how to keep people healthy, not just track diseases once they happen. And when you look at public health in our country, until we had this recent pandemic, a lot of people really didn't pay much attention to it, and public health has traditionally been underfunded. And that's part of why the US was behind the 8 ball when the pandemic started, was we didn't have appropriate stores of equipment and personal protective equipment for the healthcare workers, for any other frontline people that were supporting our lives, like people that have the low income jobs that do day-to-day, whether they're the garbage collection people or whether, it's somebody that works delivering your packages. And so having public health kind of, at least on the, maybe not always on the forefront of your mind, but on the back of your mind, that it's really important to stand up for public health funding nationally and in your local community, and to value it, because the goal is health, not always related to disease. And, I think pretty much everyone that's on this call is thinking about how we get the best health, daily health, but also health outcomes for the people that we work with. In the US, and this is not going to surprise you, but depending on where you live, your income and your education level, there may be as much as a 15-year difference in your lifespan. So think about that.
Wow, that's incredible.
Even in your own community. Mm-hmm. And when you look at public health across the US, no matter what, no matter how wealthy you are, we don't fare as well as other industrialized nations. So I know this has come up before, but I just wanted that as a little bit of a reminder. There are 10 essential public health services. I'm just going to mention them, and then happy to turn the mic over to Mike. And just so you have these, because some of these are not things I even would think about on a daily basis when I think about public health. So assess and monitor population health. That's kind of the primary thing that we think about. Investigate, diagnose, and address health hazards and root causes. So there is tracking, and I think probably most of you know that when there's a disease outbreak, there are partner trackings and so on to try to, in a prevention modality. Communicate effectively. So this is the educational piece of public health. So that's educate on new information as well as anything that's existing. They are kind of the glue between some of the communities and partnerships, so they can support and help mobilize. In the state of Washington, they were very involved with identifying, with the Department of Health, with identifying the places that had ICU beds when the pandemic was at its height. And they do that kind of work as well. They are champions of policies and plans that are aimed at improving healthcare. And this may go as deeply as into, school food for kids, and the value of that it's available and that it's high quality. And then they also are well aware of all the regulatory and legal actions that are available, and sometimes need to use those in order to improve the health of the population. This sometimes gets individuals upset, because what the individual wants and what's the right thing for the population may be a clash. And we know this about mask wearing and some of those things. And then part of their part of their goal is to build a diverse and skilled workforce. So we've talked about diversity. It is key to public health. The inequities in health and wellness in our country are front and foremost for public health officials, as well as the workers that are formally employed by public health agencies. And then, of course, to improve and innovate. So, they coordinate. We had Larry Corey, who's a virologist who was early in the pandemic speaking to us. And, the research work that he does feeds into the kinds of things that the public health agencies then can disseminate. And then the last thing is to build and maintain strong organization and infrastructure for public health. And I think that's something we'll hear a little bit more about, because as the debt ceiling has been discussed and so on, I'm not sure. I'm honestly not sure if there were any hits to public health, but public health, because it's a small voice, often does bear the brunt of changes in funding. So from a community perspective, I think it's really important to know that that funding is not fixed, and that it sometimes is in harm's way. So I'll stop with that. I think that the smoke that we have that's impacting the lives of mostly the East Coast, sort of Midwest and East Coast northern states, is a good sign of a public health concern that we might not think about, primarily because it's a huge problem for children, for anyone with asthma or chronic lung disease. You can't even protect yourself against that. And it turns out that the particles that are in that smoke won't be kept out of your breathing other than having something like a full N95, not the KN95. So the ones that are really tight fitting and that are meant to be occupational are the ones that folks that really have severe lung disease ought to be wearing in those states that are affected. And we, in the western part of the country, we typically see smoke as well as the summer goes along. So good for you to know that the standard KN95 that I wear most of the time in the grocery store may not keep the particles out. And it's not just the smoke itself, it's all the stuff that the smoke carries, like carbon monoxide and some other pollutants that will be in that can cause significant health impacts. So with that, I think probably a good time to switch out to Mike's comments, and thanks for listening.
Thanks, Dale. That was great overview. And I think it was a good reminder about what public health is. So thank you for going through that in some detail and setting us up for the future well. I'd now like to introduce Mike Gartner, who is the founder of Persius, which is a website that is under development, and it's aimed at understanding the cost of medical procedures, appointment, and hospital stays, making them more transparent. And I've really enjoyed getting to understand what Mike is trying to do. He's going to start us off by sharing how he came to get involved in this whole shebang. And with that, I'd like to turn it over to Mike. Welcome.
Well, thank you so much for the kind introduction and for inviting me. It's an honor to be here with you all. Very excited to speak with you all and hear what you all have to say as well. So a little bit of background about me. My background is in math and machine learning professionally, but more relevant to this talk, I have a long background as a patient with a chronic disease. So I have lots of experience dealing with all sorts of issues in our healthcare system, as I'm sure you all do as well. Things like billing and insurance, denials of coverage, trying to estimate costs in advance, often unsuccessfully, and dealing with specialty medications, things like that. So my own personal experiences with those issues, as well as seeing the issues of my friends and family, and then just acquaintances as an American citizen, or as an American inhabitant, I should say, you meet people all the time talking about their issues with the health insurance system, and it can be very frustrating and very difficult to figure out what sorts of recourse you have and how to navigate the system, as you all are well aware of, more so than I'm sure, actually. So all of that led me to start this organization called Perseus, which is primarily focused initially on helping people navigate issues with insurance coverage specifically. And that focus is really for two reasons. One is that it's the thing I have the most experience with. So it's sort of a natural candidate for me to try to approach and help people with. And the other is that I think it's a particular region of US healthcare where patients have very little recourse currently. And when your insurer decides, if you're lucky enough to be insured, if your insurer decides that they're not going to cover something, it can be very difficult to make progress on trying to approach that.
Lack of power, which is why a lot of people engage advocates in this area. Yeah.
Exactly. Yeah. So that's a little bit about my background. Today, what I was hoping to discuss a little bit and then have a conversation about with everyone are two distinct things that are related mostly by the thread of relating to empowering patients in cases where they typically have little recourse. So one is hospital price transparency, which is about estimating costs for hospital care. And then the other is about appealing insurance denials. So when insurers deny coverage for certain care, what recourse do you have? So to start with hospital price transparency, I don't know to what extent this is common knowledge in the room, so I'll just start off, but please flag me if everyone knows this already. There were some rules and regulations published by the Centers for Medicare and Medicaid Services and Health and Human Services in 2019, which formally went into effect in the beginning of 2021, which basically state at a high level that all hospitals in the US, aside those that are federally managed, must publicly disclose prices for their services online. And this requirement comes in two forms. One form is that they have to publish a very consumer-friendly version of these prices. So think like an app or something that you can go to, and even if you're not particularly tech savvy, you should be able to go and look for prices on this tool. And then the other is sort of on the opposite end of the spectrum. It's a very comprehensive, but not necessarily consumer-friendly file that has every single service that the hospital offers that they have a price for in advance. So one of these things is sort of targeted at organizations and advocates and people who are more savvy and able to build tools or help patients through this data. And then the other is targeted sort of directly at patients and consumers to go find this information themselves. So there's a few problems that I see in the hospital price transparency approach, which is very promising and exciting generally. And those problems are that, first of all, in order for this to be useful, you need people to know about it. And every estimate I've seen suggests that maybe at most 10% of the population knows that such a rule exists. So people presumably still think that, as was the case in the past, you're sort of out of luck finding prices in advance, and charge masters are this sort of industry secret. So that's one issue that I'm hoping to address a little today, maybe among you all, or maybe just to, if you already know this, to promote sort of educating your patients about this that you advocate for. Another problem is that even if everyone knew about this, another question is whether or not hospitals are actually complying with the rules and laws. So what's to stop a hospital from saying, I'm just not going to do this, I'll break the law, I'll get a fine, whatever. So
is there any data on that?
There is, and I was just going to say, it's a great question. I've seen estimates as low as 10% of hospitals complying that are required to comply, and then estimates as high as like 60 or 70%. And the reason there's such variation, I think, is because what exactly compliance means can mean different things to different people. So there's like the very basic level of compliance. Do you have the tool up? Do you have a file? And then there's another level of compliance, which is if you actually open the data and you use it and you go to the hospital and you get a service, is the price accurate? And if it's not, is that considered complying? It's a little unclear. So compliance is a big thing that people are trying to improve. And then I guess the third issue I see is that we need a mechanism for recourse for consumers and patients if the price that you were estimated or you're given an estimate for is inaccurate. So what do you do if you use this tool, you figure out some service should cost $300 out of pocket, you go to the hospital, you get the service and they charge you $1,000. Who do you turn to? And right now, I think, frankly, this is just an opinion, a speculation, but I assume from what I've seen that CMS is a little bit underwater trying to maintain all of this. And it's not exactly clear that they have the capacity to support individual requests from people dealing with these issues. The other disclaimer I wanted to add, I'm sorry, I should have said this at the very beginning, is that I am not a lawyer, and this is all my sort of layperson's interpretation of what these regulations say. So please take it with a grain of salt, and we'll provide some resources after this talk with links to the actual regulations and CMS guidance, so you can sort of take everything I said with a grain of salt and do your own reading and see what conclusions you come to. So with that, I think that's sort of the high level overview that I wanted to pitch today, is just awareness of these rules, making sure that people know about them, that you're using them to try to empower your patients or yourself to find prices in advance. That's super useful. It can help prevent medical debt, can help prevent really unfortunate situations where you get huge bills that you weren't expecting.
And I just wanted to make a plug also for, we had, oh, now I just lost it. The organization that helps people with medical debt. $4. Yes, thank you. $4, and people might have remembered that we had Elise Goldman, I think was the person who we had on from that organization. Do you work with $4?
I do not work with them, but I'm familiar with their work and love it. So
yeah. So I'm just wondering, is there any organized effort, organization nationally that kind of brings together everybody who's interested in these topics and issues? Is there any kind of effort like that exists out there? Also a question for advocates who are on the call today. I don't know, Mike, if you have any.
I don't have an answer to that. I know there's lots of independent organizations working on ways to improve access to this data and use of this data. And then I know CMS themselves, along with HHS, holds, they've held a few sort of calls for input from the community about ways to change the regulations and things like that. But that's all I know. So I'd love to hear as well from anyone.
Excuse me. So throw in the chat if you know of any universal resource there.
I mean, I know Washington Health Alliance in Washington State has done work around this issue, but it's not national. So I'm sure there are other local organizations working on it. So.
Great. Thank you, Beth. So Mike, you're going to next talk about appealing insurance.
Yeah, that's right. I was actually just going to break and ask. So I made a video describing sort of in practice how one would go and find these two pieces of data that are supposed to be made available by every hospital. So I guess we'll post a link to that, and maybe at the end, if there's time, we can.
Or maybe why don't we just go through it right now?
Sure. Yeah.
Okay,
great.
There's a video. So when Mike is posting the video, you'll want to just turn your volume up so you can hear it well. Okay. Thank you.
So just to set the stage again, this video is going to show me not so eloquently sort of fumbling my way through looking for the file that one can download, as well as the consumer-friendly tool that one can access for a specific hospital that happens to be right near where I am in Philadelphia, Temple University Hospital. So let me start it here. So we'll start off here by just searching for our hospital name, followed by a keyword like price transparency, for example. Could also try transparency and pricing. And the first result here you'll see is for Temple Health. It's the hospital we're looking for. So this is the hospital's price transparency homepage here that we're looking at. And from here we'll be able to access both forms of the price transparency data. So let's start by trying to access the consumer-friendly tool. So to do this, we can look for language on the page that involves estimate or consumer-friendly. So we see it referenced up here on the top. And if we continue scrolling, we should be able to find a button or a link to the actual tool itself. And if we follow that link, we'll go to the tool. So here we are on the tool, and we'll just follow the instructions to search for services we might be interested in. So we'll go ahead and select our relevant facility here. Let's say I'm going to Temple University Hospital's main campus. And we'll follow the instructions to enter some information as requested. So now that we've entered that, we're on this page that's going to help us try to actually look for the services that we're interested in. So let's assume, for the sake of this example, that we're interested in trying to estimate the price for a laboratory test, in particular a basic metabolic panel. So we'll select laboratory here, and when we do that, we see actually immediately the first hit is this basic metabolic panel. So if your case is not quite this easy to find, usually you can search by other means. But in our case, we can progress since we've already found the service. And we'll see that next, Temple's asking for some insurance information to be entered. So I'll go ahead and enter my insurance here. And when I do so, we see I'm led to this payment estimate page. So these, depending on the tool, can include different information. They might include things like out-of-pocket costs for those who are insured, or cash prices for those who are uninsured. So it's important to check the details here of what exactly you're looking at. And then finally, we should be sure to keep records of anything we found here. Screenshots or pictures could work of this page, or in nice cases, as you can see here, the hospital itself might provide some tools to take pictures or send emails of the records to yourself. So that was the consumer tool. And next, let's move on to thinking about the machine-readable files and how we can use those to access price information. So let's go back to this Temple Health Hospital Price Transparency homepage. Now we're going to look for something that indicates an actual file that we'll download. So we see here on the bottom of the page a reference to comprehensive machine-readable file. So we'll go ahead and follow the link attached to that. And when we do, we're brought to this next page, and let's scan this again, looking for files to download here. So here we see on the bottom a download files section. So we'll go ahead and download that file. And if this file is a CSV or Microsoft Excel type file, we'll just go ahead and try to open that with a spreadsheet editor. And here we are looking at the machine readable file. So this, in this case, is just a spreadsheet. And the way this works is each row is a service, and each column indicates some aspect of the data reported for that service. So here in particular, let's see, we can see charge description is a description of the services. DRG and the CPT codes are codes for the services, self-pay cash prices for those who are uninsured. And if we keep scrolling,
But they're all not
we see
available.
some insurer-specific negotiated rates columns. So let's go ahead and try to do the exact same thing. We'll try to estimate the cost of a basic metabolic panel, assuming a Cigna insurance plan.
So we could start by attempting to search for the description of the service. So I'll search here for comprehensive metabolic panel. And we found that pretty easily, but again, if we had failed, we might need to, for example, search by CPT code if the description wasn't clear. Maybe you have to Google to figure out what that code is for the service that you're interested in. So the next step would be to look in this row at the column that corresponds to our insurance status. And we can see in these highlighted cells the negotiated rates for these services for Cigna. So it looks like they are about $10 depending on which type of lab. And we can use that to inform what the total cost might be. So that's it. That's a basic intro to using these price transparency files. Hope it was helpful.
Yeah,
So
oh,
I'm sure
please.
that people have questions about that. Like when you were looking at the file, it looked like a lot of the columns were not filled in or NA, or is that typical?
Yes, that's a great question. I couldn't find the unmute button during the video to respond to you, but in that particular case, the unfilled columns were like, for some reason, Temple had like the first 100 rows weren't actually services. They were like some metadata or something. But this is a very pervasive problem among these files, is that they're completely non-standard. So every hospital you go to is like a snowflake, and they have their own special way of putting it in the file, which is very problematic when you try to go to a bunch and compare them, because you don't know if you're comparing apples to apples or not. So it's a big problem. They're very messy.
So for people that are trying to estimate costs and advocates that are trying to help patients do that. So the metabolic panel was 1098 or something like that. So how do you even go about talking to your provider or the financial part of your provider to make sure that that's correct? And do people do that?
That's a great question. I can't speak to how often people do that, if at all. I think what I would try to do would be to contact, typically, I think hospitals have financial services departments or
Mhm.
financial finance departments, basically billing departments. And representatives from those departments are probably the most educated about these rules among staff at the hospital, I would guess. And so I might try to find one of these estimates myself, and then particularly if the cost was expected to be high because the service were more complex than a basic metabolic panel, for example,
Mhm.
I might contact the department and say, here's what I did to use your estimator tool. Can you verify that that
Mhm.
sounds correct? Because you don't want to leave it up to some, mistake in the file if it might be a $3,000 out-of-pocket charge or something,
Right, right. I mean, I know in prep, and we talked a bit about this, that one of the previous times that I had a colonoscopy, the provider said, so here's the cost for the colonoscopy. If we find polyps, we will remove them, and this will be the cost. And if there's a perforation, which is a very typical thing to happen, this is what the cost will be. And then I had to go back to the insurer to just verify that they would cover that, or what part of that would be covered. So that's kind of it's like basic, but that's kind of how people typically would be using this tool.
Yeah, I think that's right. And it gets very complicated in those sorts of situations, I think, as you illustrate, because there's this whole dependency chain of, yeah, the cost should be this row, but maybe not if, some anesthesiologist comes in or something. And yeah, it gets complicated. So this is by no means a silver bullet, unfortunately.
So I think what people are particularly, excited to hear from you about is what kind of tools do you have to appeal insurance denials? You've done all the homework, you're all lined up, you're ready to go, and then something happens and the cost is different or the procedures are different. So
yeah, that's a
take
great
us through that.
segue. Sure. So okay, so maybe just to set the stage, I think everyone's familiar with this, but I'll just say it just in case. So when I talk about insurance denials, for me, that means sort of the following situation. You get some care or a service, and then there's a post-service claim submitted if you're insured to your insurance on your behalf, say from the provider. And typically what you hope for, what you expect, at least if you're getting something relatively routine, is that you get the service, you get home, you get an explanation of benefits in the mail. The insurer tells you what portion of the service they'll cover, what portion they won't, what'll be your responsibility. Provider bills insurance according to that explanation of benefits, and then you get some patient responsibility based on the copay or something like this. So that's the sort of fortunate and typical situation. The unfortunate situation that happens very frequently is that you go through those first steps of getting the service, and then you get an explanation of benefits that says, in fact, we aren't going to cover what just happened. It's precluded by your contract for some reason. We're not covering this, so it's actually fully your responsibility to pay for this. So that's what I refer to when I'm talking about an insurance denial. And these denials are extremely common. I can get to some numbers shortly, but a distinction, one way I'd like to display a dichotomy between two types of denials that can happen, which are what I'd call contractually appropriate denials or contractually inappropriate denials. This is sort of my own terminology. Take it with a grain of salt. I'm not a lawyer. But what I mean by this is sometimes you get a denial and there's nothing inappropriate about the denial. It is the appropriate action based on the insurance contract that you have and based on the situation that happened. So those happen all the time. Things like a provider accidentally submits 2 claims for the same service, which of course the insurance company is going to say, why would I pay twice for this one service? That's crazy, as would anyone else. And so they deny one. That's a contractually appropriate denial. The contract that you have with the insurance company says we're not going to pay twice for the same thing. That would be absurd. Other contractually appropriate cases. Your insurance plan happens to say explicitly, completely clearly on some page of the contract, we will not cover X. We just won't do it, whatever X is, some service. And then you go get X done, and they say, we're not paying, as it said very clearly in the contract. That's what I'd call a contractually appropriate denial. It's unfortunate. It might lead to bad situations. Maybe it should be changed via policy that they're allowed to deny those things. But contractually, it's all consistent or seems appropriate. A very different situation is something I'd call contractually inappropriate denials. So this is where you get some service and your insurer says, we denied it because on page 3 of the contract, we describe what we mean by medical necessity, and we think what you got wasn't medically necessary. And then you go read the contract and you say, wait a second, what they defined to be medical necessity is completely consistent with what I got. What I got was medically necessary by their own definition. So that's what I'd call a contractually inappropriate denial. Even by the contract's language, it seems like it was inappropriate that the denial happened. And that latter category, that contractually inappropriate denial category, is the one that I'm focused on with the tools we're building at Persius, because those are the cases that are very tractable, even by law, I think. I'm not a lawyer, and that regulations protect patients for. Mm-hmm. Regulations do not currently really protect patients in the cases where the contract itself says that something's not covered. Okay, so sorry, that's a huge preliminary. But these sorts of denials, these contractually inappropriate denials, occur frequently. To give you some sense of the scale, in 2021 on healthcare.gov plans, among healthcare.gov plans, so federal marketplace, 16% of all claims submitted under those plans were denied. Can't say whether those were appropriate or inappropriate contractually, but that's a huge percentage. 16% were just denied flat out initially. The question is, what happens when you get a denial and you think it's inappropriate? Well, consumers typically have recourse. There's the exact details depend on your plan. They depend on where you live. They depend on all sorts of things like whether the coverage is sponsored by your employer, whether a RISA applies, which is some relevant piece of law. But typically, no matter the situation, consumers are able to appeal a decision, and they're able to do that in two stages. First, to their insurer. So the insurer will be responsible for accepting the appeal and adjudicating it. And people call those sorts of appeals internal appeals because they're sort of still internal to the insurance plan. And then depending on the outcome of the internal appeal, consumers typically also have recourse to externally appeal, which means you appeal, but the person or the entity adjudicating the appeal is no longer the insurer, but some third party, presumably less biased entity. So to give you a sense for the scale here, this is very useful recourse, I think, for consumers and what we're trying to promote as a more common pathway for recourse for patients at Perseus. And to give you a sense of the scale for how often that happens, among those same plans on healthcare.gov in 2021, we heard that the denial rate initially was 16%. Well, the internal appeal rate among those denials, the occurrence at which they're appealed, was about 2 out of 1,000 or 0.2%. So virtually no one or virtually no claims are being internally appealed. 0.2% of them are. But among those that are internally appealed, among that 0.2%, 42% win. They get the denial overturned.
So this is to the insurer, just to remind people, this is to the insurer. 42% are overturned. So basically the bottom line is make sure you try to contact your insurer. Don't just pay if you think it's wrongly covered.
Absolutely, absolutely. And then similarly, among those that are, so if you internally appeal, you might win your internal appeal, you might lose your internal appeal. If you lose your internal appeal, you typically have recourse to do that external appeal. That happens in that same population of healthcare.gov plans. Among the internal appeals that lost their internal appeal, so the initial denial was upheld, about 5% keep going in the process and externally appeal, go to the next level. But of that 5%, 50% then win their external appeal. So it's like this, to me, it's a very compelling story that consumers have a ton of power to go through these appeal processes and win. And statistically, they're very likely to win when they actually go through with it. But the data also show that consumers and patients don't
have the stamina.
Resources
they don't have the stamina.
Right? Exactly. So this is sort of the whole point of Perseus. What my motivation is to try to get more people to do this, to help them in the process, and ideally, as a result, get more people care that they need, and maybe long-term even change insurer behaviors for some of these denials. So after this talk, I'll distribute an infographic I made that sort of walks you through the steps of going through this process. I've done it many times myself personally. I've helped other people go through it. It's a little bit arduous, but it's serious when you are being denied care that you need, and it costs a lot of money and you can't afford it otherwise, right? So
yeah, and Sherry Maxwell just sent a message that's really great, which is it's so important to remember that an insurance policy is a contract intended to cover general health issues. Understanding the limits of these contracts is useful. Denial is not an indication of treatment needs, merely of what the document covers up to the policy limits. Most miscommunications with insurance folks break down to misunderstanding of how the insurance works. No one would want to pay for the cost of a policy that covered everything a patient might need. And so thank you for Sherry for sharing that perspective. It's very good. And also Lisa Casaro says, and appeal according to the instructions in writing, usually to specific departments and divisions. Be sure to watch the window of opportunity for appeals processes. So there's a lot of fine details that if you are sick, if you are, not doing well, it's very hard to make it through, have the stamina. So also Kai asks for clarification, Mike, did you say your website or product focuses on the area of contractually inappropriate or appropriate? And what kind of data will it supply?
Yeah, great question. And thank you for the comments from the other folks. I forgot your names. I'm sorry. But those are very great points that I agree with. I said that the product for Perseus will focus on the contractually inappropriate cases. And this goes back to someone else's comment previously that, at the end of the day, of course, no one wants to pay for everything. No insurer, it would be hard to maintain a business where you paid for everything. And so I think a more reasonable thing to target is to make sure that they uphold their contracts as they themselves wrote them. So I focus on the cases at Perseus where insurers don't seem to be following their own contracts that they sold consumers.
Yeah, that's great. And I just, somebody said, I didn't see the post from Sherry. So I just copied and pasted it in case you wanted to know the words that I just read to everyone. And keep your questions coming in the chat. That's very helpful. So Mike, what about contractually appropriate denials? What kind of power do patients have in that regard?
Yeah,
maybe less, but
I'll start off by saying I don't know. I know a little bit, but I don't know the full extent. So please, anyone jump in if you have other suggestions. Certainly you have less recourse because at the end of the day, insurer's obligation is detailed in their contracts. That's what they sold as a product, and that's what we've bought as consumers, or our employers have bought, or what have you. And so when they're not obligated to pay by their contract, they're probably they have good legal teams, they're probably not gonna pay. But you might still have recourse if their contracts aren't consistent with regulations that exist about what needs to be in their contract. So sometimes you'll see cases where a contract says something very clearly, and you think, okay, I'm out of luck. The contract did say that's not covered. But then, I'm not a lawyer, but you learn about some regulation or law that says, oh, in fact, insurers, have to cover this, or they have to make accommodations.
Because sometimes it changes, right? So
exactly. So like the Affordable Care Act added a bunch of required qualities, for example, to qualified health plans and define that term. So there's always changing law about what needs to be in contracts. So that might be one recourse if you think, if you talk to someone more knowledgeable than myself, you might learn about regulations that help protect the sort of service that you're seeking.
So that makes me wonder, and Deidre Kindred asked this question too, in terms of your website, the Perseus website, what will specifically be on your website and when will it be launched?
That's a great question. So unfortunately, I have to be a little bit ambiguous about the launch date. I'd say within the next 2 months is the goal.
Okay,
I don't have
that's pretty soon.
date.
All
Yeah.
Right. Before the end of the summer. Okay.
Yes. And initially, the question about what is contained on the site is sort of related to the launch date. I'm sort of trying to add more and more to it, so I'm pushing the launch date back. But initially, it'll effectively be a patient advocacy tool to help folks navigate their insurance contracts, particularly for appealing. So if people get a denial they think is, maybe they're not even sure if it's contractually inappropriate, they can come to us, they can send a message, and me or someone who works with me will look into their situation, look at their contract details, try to help them understand whether or not the service that was denied was contractually supposed to be covered or not. If it was supposed to be covered, we'll try to help them appeal it. If it wasn't supposed to be covered, it seems like a contractually appropriate case, we might send them to someone else who's more knowledgeable and can help them more with that sort of situation.
And will people have to pay for the service, or what's the funding model for what you're doing?
Yeah, this is still in the works. The idea is that it's going to be free for consumers and patients, end users, and the funding and revenue will come from charging other folks. So if people themselves are going to use our tool to help 100 people, for example, because they work as a patient advocate, or if a hospital wants to use our services to internally have the providers appeal via our tools, then we'd charge. But for end users, individuals, it'll always be free.
Okay, that sounds
So
great.
Mike, in prep, you shared what I thought was very user-friendly tool, an example.
Oh, the step-by-step guide, is that?
Yeah, I think that might be helpful to just see.
Sure, yeah. Let me share my screen here.
And I do want to say that as a follow-up to our call today, we will be sending out this tool, so you will have it for participating today. And it'll also be posted on our website with the rebroadcast.
Awesome. Yeah, so this is the tool. Thank you for bringing this up. So this is basically a little infographic. I apologize, I'm not a designer. I made this, so bear with
It
the
looks good.
design.
Looks great.
But basically, it's a step-by-step guide that walks you through roughly what the timeline of navigating an appeal process should look like. So as I mentioned, the details, it's very hard to make an infographic about this because the details are super dependent on all sorts of minutia. So where you get your plan from, whether a RESA pertains to your plan, all these things. So the details are going to change. The exact dates by which insurers have to respond to you, how long they have, that's all dependent on your particular situation. But roughly, the steps are always the same and they're pretty straightforward. So roughly, they're the following. First of all, in order to appeal a denial, you have to get a denial to even be in the regime of wanting to appeal. And
Good point.
Thought I'd clarify that. So you get a denial and you should, first of all, review it, genuinely try to understand what the insurance company has said about the denial. Again, it might be one of these contractually appropriate cases. Maybe it's something silly like, they just got a duplicate denial and of course they're going to deny and then you have nothing to be appealing, right? It's just, it makes sense. I'm guilty of this. I just got a denial last week for some continued physical therapy that I'm doing for my knee. And I got the denial and immediately it was like, I'm out the door. I'm going to go appeal this thing. Like, this is crazy. And then I read it a little more carefully. I was like, wait, actually, they're not denying my physical therapy. They're denying it continuing indefinitely, which is pretty reasonable. It shouldn't continue indefinitely in my case. So yeah, read it, try to understand what it's saying, see if you agree with the rationale. It might reference a bunch of things. It might reference the contract itself. It might reference clinical policy bulletins that the insurer releases. So go look at what it references, see if you agree, if you think it's contractually appropriate. Assuming you think it's contractually inappropriate, then there's a chance it's contractually inappropriate. There's recourse to try to appeal, or there's reason, I should say, to try to appeal. So you might move on to step 2, which I would say is similar to step 1, just do your research. So gather documentation, try to understand relevant clauses in your full benefits contract. So as a reminder to folks, this is not like the summary of benefits, the 1-page thing. This is like the, probably 100-page PDF that you get when you sign up for a plan that has every single stipulation about what they cover. So try to look for relevant contract clauses, maybe look at the clinical policy bulletins in more detail. Those themselves like reference scientific papers often. So if you feel up to it, maybe look at those or look for an advocate who can help you look through those. In some cases, you can request what's called an insurer claim file. So pretty much in all cases, you can make a request to the insurance company that they have to abide by, which says, I'd like all of the data you have pertaining to this claim denial that you've sent to me. So this would include things like prior correspondence with them. Sometimes it's overboard to ask for this, or not overboard, but not super useful. But other times there might be things you want records of that they have that you don't have. So that can be useful sometimes. So once you've done your research,
The
you
policy jacket is what Sherry Maxwell was. How does the policy jacket help? Is a question.
the policy jacket. Sorry, did I
Not
say
quite.
that?
It's a question
Or
from
is it-
Sherry.
Sorry, Sherry, could you clarify what you mean by policy jacket?
If I can I'm trying to find her. Here we go. Sherry?
Yes, I'm sorry. I was going to ask Mike about, he was saying how getting data from the company about previous claims. I'm not sure how that helps.
Oh, I'm sorry. I think I misspoke. I was just
That
saying. I
feels like
wasn't.
muddying the water.
I wasn't referencing, or I didn't intend to reference previous claims. I was intending to reference the claim in question. So sometimes you can have things like situations where, like, maybe before getting a service, you had a lot of contact with an insurer, back and forth via email or phone or something, where you were saying, like, I'm trying to understand if this is covered. Do I need prior authorization? Something like this. And sometimes when you get a denial, you might not have records of all of those correspondences, but the insurers certainly do. And so I've been in a few occasions where I've requested this sort of, like, all of the insurance company's records about a particular claim that was denied, and they'll send you, for example, I mean, whatever they have, which is not always everything, but they'll send you email correspondence and things about the claim.
Right. And my question was more about how is that useful to somebody who's trying to get something covered?
Oh, I see. So what I've done before in appeals is I've referenced that. So if you're, for example, some denials can occur if you don't receive prior authorization, and insurers have particular policies in place for what the process of prior authorization must look like in their particular plan contracts. And if you abide by the prior authorization process and you get prior authorization, and then they deny the claim saying you didn't receive prior authorization, that would be very useful to have on record that you.
But something like that is easy to prove in court. I'm just wondering about why you would ask the insurance company for the information that you have been communicating with them. Do you understand what I'm asking?
I'm not sure that I do, but
I mean, say you get a pre-approval and you go in and have the procedure done, and in the course of that procedure, some event happens, something outside of what the medical community has forecast happens, and they take care of it for you. Then your insurance company is not responsible to pay for that unless it's in their policy language. Does that make sense?
yeah,
So
that
they
makes sense.
can approve part of it, even if it's pre-approved, and they can still deny the claim or whatever, because something in their language is an indication that that kind of thing isn't covered.
Oh yeah, I'm with you that sort of situation makes sense. That can happen. And in that case, I think the claim file wouldn't help.
So we're almost at time, so I'm gonna ask Mike to please wrap up, and certainly if anybody has any other, questions or anything else, we're gonna have a follow-up email that has some of Mike's tools. So Mike, any other, not to cut everybody off here, but I want to make sure that we end on time. Any other final comments?
I think that was it. But thank you all so much for being here. It's a real privilege. And I'm sorry, I've forgotten the name of who was just speaking, but I'd be very happy. Sherry, I'd be very happy to continue the conversation offline if that's useful. And we'll distribute this guide so you can sort of walk through it. Please let me know if you have any questions or reach out to me. I'll send my contact info.
Sounds good. And I just wanted to let people know that in the chat, there is an organization that focuses on insurance. Krista Multilianus, My Care Navigation at accesstpa.com. So we'll go ahead and make that available for the follow-up as well. And Dale,
And Robin,
yeah,
oh, sorry, this
go
is
ahead.
Krista.
Yeah.
Yeah, so there's 3 navigators on here. We all work for the insurance company for HMA. So I just to point out, it's a requirement that we also have comply tools. So that email is just if anyone has any high level questions on what we're doing on our side to meet that requirement, we'd be happy to answer those questions.
Great. Thank you so much, Krista.
Sure. Thank you.
Really appreciate that. Dale, do you have any other final comments?
No, I just wanted to wind up with, I think this is one of those areas with healthcare where collaboration is super important. Mike, I really appreciate your presentation today, and also how we best work with the insurance coverage we have is a way to get the best outcomes in some respects. And I think that comments that insurance is what it is, and it isn't everything, is super important for us to think about as well. How do we supplement that insurance with our everyday good health attempts, and make sure that we advocate for ourselves and advocate for our clients when things appear that they're not going the way they should. And I think your company would be a great example of that, especially with their focus on what the insurance is saying they're going to do and what they're denying. If it's not congruent, that's a perfect place to have a site like yours. And thanks so much.
Yeah, wonderful. Thank
Yeah.
you.
Thank you, Mike. Thanks, Dale.
Thank you, Mike and Dale. And I just wanted to remind people that next month on our community conversation, we're actually going to have Io Dolka, who's founder of Gray Zone Health, and she's going to be talking about diagnostic advocates. So advocates focused on the diagnostic process and making a tangible difference in helping patients get an accurate and timely diagnosis. So that will be same time, same place next month, July 10th. So I hope to see you there. And don't forget to sign up for case review at info@healthadvocatex.org. I know we went over 2 minutes, but thank you, everyone. Really appreciate it. Bye-bye.
Thank you all.